Health. My name is Shelley Adler, and I have the pleasure of serving as director of the Osher Center. Today, I'm delighted to introduce Drs. Chloe Atreya and Kavita Mishra. I'll introduce them individually, and then we'll explain what happens during the presentation. Dr. Atreya is Associate Professor in the Department of Medicine, Division of Hematology and Oncology at UCSF. She specializes in gastrointestinal cancer care, particularly colorectal cancer. This is at the UCSF Helen Diller Family Comprehensive Cancer Center. Dr. Atreya also she co-directs the Integrative Oncology Program and Research Hub. Gives me great pleasure to say that she's a faculty affiliate of the Osher Center. And she does wonderful work mentoring our pre- and postdoctoral fellows in our NIH T32 and T35 fellowship programs. There's the Training and Research in Integrative Medicine and the Integrative Health Equity and Applied Research fellowships. Dr. Atreya's research focuses on the interplay of tumor genetics and response to therapies for colorectal cancer with the goal of improving patient outcomes and quality of life by personalizing treatment. She is a diversity, equity, and inclusion champion and strives to address cancer disparities in research and clinical care. Now on to Dr. Mishra, who is a professor in the Department of Radiation Oncology here at UCSF. Her clinical expertise is on the treatment of uveal melanomas and proton beam radiotherapy, as well as plaque brachytherapy. Her practice at the Osher Center emphasizes mind-body and builds on practical health resources for lifestyle changes to coordinate care with patients' medical, radiation, and surgical pathway. Our current research focuses on the clinical outcomes of uveal melanoma patients, particularly with respect to tumor control, preservation of the eye, and quality of life issues. Dr. Mishra is active in the Integrative Oncology Working Group. She's a mind-body co-lead, and she's also a member of the Society for Integrative Oncology's Health Equity Committee. So I'm delighted to be introducing our speakers for today. And I also want to note that something else they have in common is they completed our Osher Collaborative Faculty Fellowship. Look what can happen if you have this kind of training, and co-lead the Integrative Oncology Group through the Cancer Center. So in terms of the plan for today, after we hear from our speakers, we'll have approximately 15 minutes for discussion. I want to encourage you to submit questions directly to me by way of the chat. But during the Q&A, I can also call on you if you have questions you'd like to pose in person. So last but not least, I want to thank the people behind the scenes who pull our wonderful Grand Rounds program together. The planning committee, including Selena Chan, Anna Druva, that was Anand Druva, and Patty Moran, as well as Jen Shea, Yvette Coulter, and Julia Burns. So please join me in virtually welcoming our speakers, and we look forward to learning from you today.
Great, good morning. Thank you, Dr. Adler, for the kind introduction, and to the organizers for inviting us to present today. Dr. Mishra and I are very excited to share what we've learned about mind-body medicine and oncology group visits from developing and piloting a mindfulness-based intervention tailored for diverse patients with cancer. I'm requesting remote control. 1 second. There we go. All right. As an outline of our presentation, we will summarize evidence supporting mindfulness-based or mind-body medicine and mindfulness-based interventions to address common symptoms experienced by people with cancer and to support behavioral change. And notably, distress, anxiety, diet, and physical activity have all been linked with cancer survival outcomes. And we will describe the unique purpose, structure, and content of our group medical visit series, serving diverse patients undergoing cancer treatment. We will present quality improvement research results. And finally, we will discuss tailoring using an equity and empowerment framework. And our learning objectives include summarizing the rationale and clinical data for mind-body medicine and group-based cancer care, to analyze critical gaps in the evidence base for understudied populations, and also to reflect on the utility of group medical visits to address disparities and access to integrative cancer care. I'll pass it to Dr. Mishra.
And I'll just take a moment to make sure on the technical side that, Jen, we're good in terms of seeing the slides.
Yes.
Perfect. All right, so as a starting place, we always want to make sure that tech is good. And we also really want this hour to be as relevant to you as possible. And so if there are questions, you can place them to Shelley or place them in the chat, and we'll see if we can weave it into our presentation and the Q&A. And we also invite you to take a breath with us as we begin. I'm going to as well. So throughout my career, at least as a radiation oncologist, I have worked with super complicated machines, the size of tennis courts, lots of wires, but there's literally nothing more complicated than the human mind-body complex. And for thousands of years, mind-body medicine has been used for clinical benefit. It's defined as a diverse system of practices that focus on the interactions between the mind, body, and behavior to promote health and well-being. And this can include meditations, breath, body awareness, kindness, compassion training, movement, which is really important for many of our cancer patients, yoga, qigong, tai chi, relaxation techniques, expressive techniques, which often don't get thought about naturally by patients, but things like dance, art, writing, music can be very meditative practices, nature medicine. And we know from really well-established data, randomized control trials, meta-analyses, systematic reviews, that patients benefit in numerous realms. And that can include physical symptoms like sleep, fatigue, nausea, pain, psychosocial issues like stress, depression, anxiety, fear of recurrence. And as we go through the cancer journey, there are a lot of cognitive and existential questions that can come up. And so the wisdoms that we may gain from meditational practice may increase awareness, self-compassion, gratitude, insight. And now there are really wonderful national guidelines that many of the people in this room have worked on through the Society for Integrative Oncology, ASCO, the National Comprehensive Cancer Center, Cancer Center Network. And these are clinical practice guidelines based on all of that data that include integrative oncology approaches, particularly mind-body approaches like meditation, mindfulness-based stress reduction, yoga, music. And one of the meditational types that's been widely studied in the modern health setting is mindfulness meditation. And mindfulness can be used in a lot of ways, which maybe we'll go into in the Q&A. But for this purpose, we're talking about mindfulness in the realm of mindfulness-based stress reduction and mindfulness-based cancer recovery, which are really well-established 8-week programs that have been studied in the healthcare setting. Many of those studies, prior studies at least, have been conducted in predominantly Caucasian patients and often in breast cancer survivors. And so the other thing is MBSR can be quite intense for patients because it's 8 weeks, and to really do it to its most impact, you want to have daily homework that can be anywhere from 15 to 45 minutes. And so part of the inspiration for our group medical visit came from the MBSR and BCR programming, as well as the Center for Mind-Body Medicine, which has a wonderful program that Judith Cuneo actually told me about a while back. And it has many overlapping concepts with the MBSR. The format is also 8 weeks, and they teach multiple meditations from across cultures across the world, and it involves about a third of the time learning mind-body medicine for patients, about a third of the time practicing techniques, and about a third of the time sharing as a group. And some of the examples are, as pictured here, drawing, writing exercises. There's a shaking and dancing exercise, which I particularly am fond of, which has some indigenous roots, African, South Asian roots. And ultimately, Dr. Atreya and I were inspired by all of these concepts and more to make a hybrid format that we thought would really work for patients. Dr. Atreya?
Thank you. As many of you know, in 2014, after participating in MBSR at the Osher Center, I developed the Being Present program, mindfulness-based intervention for MBSR understudied populations. And specifically, together with Kubo and a team of others, we set out to design a feasible and acceptable distress reduction program for the folks who I see in clinic, who are patients in treatment for metastatic GI malignancies and also their family caregivers. And many patients now live for years while undergoing treatment for metastatic cancer, providing an opportunity for tailored interventions. We learned a lot from the Being Present 1 and 2.0 audio and then web-based interventions that we conducted prior to the pandemic, and during which we conducted a large number of interviews. Being Present was tailored to be less intensive than MBSR, and we found it to be feasible and acceptable for patients in active treatment, with significant reductions in distress scores. There were also several limitations, including that Being Present enrolled predominantly white and non-Hispanic patients. Attendance to the Zoom sessions as part of the web-based intervention was poor, and we received feedback that some patients feared that addressing distress in a group with other patients with metastatic cancer could be destabilizing. Also, Being Present was entirely dependent on grants and philanthropic support and lacked a financial sustainability model. And access is a priority for me, so charging patients with cancer to participate was not an acceptable option. Meanwhile, with the support from the Integrative Oncology program in 2018, Dr. Abrams started piloting integrative oncology group medical visits as a means to provide timely integrative oncology care. And this proved to be a financially viable model. The GMVs are billable to insurance and were found to be revenue generating when there were at least 6 patients in the group. And importantly, the group medical visits, or GMVs, also were met with rave reviews, both from the patients and from Dr. Abrams. And as an integrative oncology program, we have a vision for comprehensive cancer care at UCSF that is accessible, sustainable, and inclusive. And the GMVs have the potential to fulfill all of these objectives. So using a stepped care model, pictured here in the triangle, a current focus of the Integrative Oncology program is on expanding and evaluating group-based cancer care offerings. And I'll now shift to talking about the mindfulness practices group medical visit series that Dr. Mishra and I launched about a year ago. Our series has an intentional disparities focus because racial and ethnic minorities experience worse cancer outcomes and have less access to integrative oncology care. And to improve access, we designed, piloted, and conducted quality improvement analysis for a series of mindfulness-based GMVs tailored for these diverse patients in active treatment for advanced cancer. And as an entry point, the series has a pro-health emphasis rather than focusing on distress reduction or fighting cancer. The inspirations for the series, which we share with patients in week 1, are that evidence-based guidelines exist, recommending mind-body practices that can alleviate symptoms and also lifestyle factors that have been shown to improve cancer outcomes. How to implement these behavioral changes is the hard part. And while mindfulness practices can help, and fortunately free and high quality resources are available, a challenge is that we live in an age of information overload, which also means that it's difficult to find time to focus on these practices during a usual oncology visit. So our intention is to help patients to select and commit to a few simple practices. And the emphasis here is on practice, as repetition is key. On the other hand, these repeated practices can be straightforward, brief, and hopefully enjoyable. So I'll talk a little bit about the group medical visit pilot structure. So it's we hold them on 4 Fridays, sequential Fridays from 10 a.m. to noon. And importantly, each session has 2 facilitators. Dr. Mishra and I co-facilitated together for several rounds, and I've now also worked with 4 other co-facilitators. MDs and NPs can bill for their time or complexity, and RNs have been able to dedicate education time for resilience and skills building. And our team is continuing to refine manualization with built-in flexibility for a sustainable co-facilitation model. And each series has 8 patients, and we aim for at least 50% BIPOC enrollment. Oh, I skipped over that a very important piece is that we have either a research coordinator and or a practice coordinator who joins us for the visits. And this support is crucial for facilitators to be able to embody mindful presence during the visits. And it also contributes to our strong attendance. And I'll note that we have several patients for whom English is a second language, and these patients often benefit from additional tech support. As I mentioned, we aim for at least 50% BIPOC enrollment, so we offer slots to BIPOC patients first. And recruitment at this time is mostly word of mouth. I invite all English-speaking BIPOC patients who I see in clinic to join the groups. And there's time for both group and individual structured time, and I'll go into that in detail on the next slide. And as I mentioned, we're conducting quality improvement research, which includes a baseline symptom assessment survey and a demographic survey, and also evaluations during the program. And the logistics have certainly been a learning curve, which we'd be happy to discuss in the Q&A and also in our upcoming symposium where we'll have a whole nuts and bolts session. I'll just say today that Chris Pollock's guidance has really been invaluable. So in terms of the pilot structure, I'm giving an example of an overview of session 2, mindful eating. And each session is about a third experiential, a third didactic, and a third either individual and group sharing. We start with a meditation and noting from being present that patients undergoing CT scans for cancer monitoring don't like the term body scan. We call it a body awareness meditation. We go into communication agreements, which I'll show on the next slide. We have check-ins. So in week 2, the prompt is to state your name, optionally gender pronouns, and one thing that you're grateful for. I provide a recap of the prior weeks, and I present evidence, the evidence base for the session topic, in this case, nutrition guidelines for people with a cancer diagnosis. Then I focus specifically on how mindfulness practices can support adhering to these guidelines in the face of challenges that are posed by cancer symptoms and chemotherapy side effects. Here, the mindful eating practices include practices for slowing it down and also giving thanks. And then we do another experiential practice. Here, the raisin eating exercise from MBSR. In other weeks, I lead another meditation or yoga or Qigong. And then we give prescriptions rather than homework for practices to take up with curated resources provided in the after-visit summary. I'll turn it over to Dr. Mishra for hour 2.
So hour 2, briefly, I or another co-facilitator will open with a brief meditation, and then we'll usually go into another modality to introduce guided imagery, acupressure, pranayama practice. And then the bulk of that second hour will be around a creative expression practice, which can be art, dance, music, And in this example, it was a creative expression practice where you have a dialogue with a symptom or problem as if it's in the room facing you, and you're together, talking to each other, communicating with each other. And then once we do that exercise, we'll follow this with structured sharing as a mechanism to really explore our own inner wisdom that comes from that exercise, and then also learn from the group's wisdom. And part of that is really practicing mindful listening, both inward and outward. If there are subjects that might arise, I might share as a facilitator mindfulness concepts, images, poetry, whatever feels relevant. And so we've built that also in that flexibility into the manualization as we've been working on it. And meanwhile, while I'm doing that, Dr. Atreya will pull out patients for individual consults, and she's really focusing on tailoring the mindfulness practices and resources for each patient, depending on their personal challenges, and any history of trauma is discussed in that hour or in that moment as well, if it's relevant. And then as we started the session with meditation, we'll also close the session with a brief meditation.
Thank you. So our communication agreements come to us from Visions Inc. in the East Bay Meditation Center, where I'm a coordinator and facilitator. And we focus on different agreements each week, hence the 4 colors. And these agreements for multicultural interactions are one way that we hold space for diverse groups. And we'll further focus on tailoring for diverse patients in a bit. But first, advance the slide. We'll talk a little bit more about the content. So similar to MBSR, over the 4 weeks, we explore 9 attitudes of mindfulness. These might be small, but they're what are in the circles that come to us from John Kabat-Zinn's work, and we pair these with the session topic. So in week 1, the topic is cultivating emotional balance, and the mindfulness attitudes that we explore are gratitude and generosity. And one of the most effective ways to overcome our brain's negativity bias is to rewire one's brain toward and rewire one's brain toward happiness is by expressing gratitude. So then gratitude journaling is one of the recommended home practices. And then in week 2, the communication agreements from the previous slide are try it on and refrain from shaming or blaming self or others. And we pair this with the mindfulness attitudes, beginner's mind, and non-judging, which are relevant for exploring our relationships to food. I'll now go into the quality improvement research. And although we're now recruiting for our 10th series, here we will show analysis of the first 6 groups, including a total of 48 patients and 9 human caregivers. The caregivers included partners, mothers, sister, daughter, and we've learned that an advantage of Zoom is the added support of cats and dogs. Okay, so demographics. The first 6 groups had 54% BIPOC representation overall, and notably each of our now 10 groups of 8 patients has had at least 50% patients who identify as BIPOC. About a third of the patients in the first 6 groups were male, and that number seems to be increasing. The median age is 53, with patients ranging from ages 27 to 74 years old. Almost half of patients were working at least part-time, and it helped that patients and also caregivers were requesting time off to attend a medical visit rather than a class. And about 80%, let me change the slide. Here we go. About 80% of patients had GI malignancies, and 85% had metastatic disease. 58% were receiving cytotoxic chemotherapy, so our standard chemotherapies that cause a lot of side effects. And patients were a median of about 2 years from diagnosis. 77% of patients enrolled, although some delayed enrollment to a future cycle. And I'll note that BIPOC patients and men were only slightly overrepresented among non-enrolled patients at 57% each. And then 77% of patients attended all 4 sessions. And missed visits were usually due to illness or treatment-related scheduling issues. I will note that the Cancer Center, Infusion Center, and clinics have been great at assisting our patients to attend from Mission Bay. And then we've had very high survey completion rates. As an overview of our baseline symptom assessment from the Memorial Symptom Assessment Scale, we saw high concordance between the most commonly reported symptoms and the group medical visit content. So 75% of patients reported a symptom related to mood, which are the ones that have the asterisks near them. And 75% reported lack of energy. And about half of patients reported difficulty concentrating and difficulty sleeping. This is prior to the intervention. And the median stress score was 5 on the NCCN distress scale. And then evaluations were favorable as reported here. So all of the evaluations are here on the slide. No one had more negative evaluations so far. And I'll now pass the virtual talking stick over back to Dr. Mishra for the qualitative analysis and a discussion of tailoring for diverse patients.
All right, and those evaluations will continue to come in, and Dr. Atreya and I have tried to be very open to all of the feedback. And part of that was also a qualitative analysis, which is to understand qualitatively how can we adapt, characterize our feedback so that we can acknowledge what's working, acknowledge what's not working, and adjust from there. And so we had feedback from patients, team members, fellows, our own reflections. And there were 4 major themes that came out of that qualitative analysis. The first is empowerment. Empowerment with knowledge, practice, wisdoms. This is all coming from the patient's either oral feedback or written feedback. And some of the topics in particular were topics of acceptance, self-compassion, that patients could feel empowered towards pro-health behavior. And a few of the quotes, I won't read the full quotes, but some of the quotes from patients were things like, the doctors have organized a concise and dynamic way to present resources we need to adapt and make positive changes during our cancer treatment and beyond. And importantly, there was a discovery of what I can do, like chair yoga, versus feeling limited in this patient's power to exercise. The second major theme that came out of the feedback was, and in our own reflection, was the critical nature of having this be experiential and very practical, so that patients left with tidbits, nuggets that they could actually bring into their life in a very difficult time as they're in active treatment. And so even simple practices that could be repeated could be transformative for patients, and patients would write in things like the balance between data and actual time spent on learning was really important. There was enough information to make constructive choices and changes without being overwhelming. The third major theme was community and the concept of group wisdom, which particularly resonates for me. And there's this acknowledgement of, yes, we have the unique human experience, our own, each individual's experience, and then also there's a commonality of human experience and connection. And this could serve as a safe space where folks could discuss challenges, what was working, what wasn't. And some of the quotes that I really loved were things like, the group format added a level of connection that makes us more receptive to trying new exercises and growing and learning. Another patient wrote in, which I thought was really beautifully written, I found solace in the idea that my experience is both entirely unique and somewhat predictable. And then he continued on to say, hearing from others who are experiencing the anxiety and stress of cancer, but from different backgrounds and with different approaches to mindfulness, was helpful and interesting. And then the fourth major theme that came out of the feedback and our analysis was diversity. Diversity not only of the people that were in the room, and also the diversity of the practices that we were trying to share. And the idea is that different tools can work for different people at different times, and what may work for me one day may not the next day, and same for other patients. And so patients would write in things like, we're a diverse group, but have much in common beyond our diagnosis. And this was a really informative balance between Eastern and Western medicine. I love this particular patient who wrote, when I sit down to meditate, I would doze off. So it's nice to learn different ways of meditating. I try to focus on my breathing while I walk, and I practice Qigong. And I want to take a minute just to focus in on the two pieces on the corners here, empowerment and diversity. To do this, we used a framework that's been used by the CDC and other health institutions. There are multiple frameworks out there. We chose this one because it resonated for me. And so there are 5 Ps: purpose, people, place, process, power. And we tried to look at the programming before, during, and post to really see were we acknowledging these different Ps, and what else could we be doing. And I'll take us through this a little bit more high level. There's a lot on the slides, but just to make sure that we have enough time for Q&A. Purpose. So the idea behind the first P, purpose, is for any programmatic development that partners align towards defining, communicating, and integrating practices towards a goal of equity. And so as Dr. Atreya very beautifully said already, our mission was very clearly to ensure that we had a diversity lens, an inclusion lens. We had patients accessing this care that otherwise may not naturally access it. And then also importantly, thinking about diversity from the team, the co-facilitators, and the structure curriculum of the program. People. And so this idea is really considering the physical, emotional, spiritual, contextual effects, and importantly, the barriers. And again, thinking about the patients, the team, the caregivers, there were a number of factors that we would consider as we were developing the program, and that was race, ethnicity, gender, age, abilities. Things like if a patient is in advanced cancer going through active treatment, yoga may be better suited as a chair yoga or allow for practice modifications with lying down. Socioeconomics, we had folks with food insecurity, housing insecurity, and how do we make sure that our language reflects that as we discuss mindfulness exercises, diagnosis, stage, treatment. We had a really interesting background of folks who had a real wide variety of spiritual, religious beliefs, folks who wanted to come in from a science perspective, folks who wanted to come in from a not so science perspective. And so thinking about how do you balance that with groups and really personalize the care across that. And then also folks came in with different prior experiences, trauma history, and finally, the comfort with language, the comfort with technology was also a piece of what we were thinking about. And frankly, the comfort in being in a group versus an individual setting. Place. This idea of the third P is how do you account for emotional and physical safety, value, and productivity? And I just want to comment that the Jetsons had it right with telehealth way back when. I'm dating myself, but it's kind of funny to see it now. And the idea here is that in terms of place, obviously we were over Zoom, and the logistics were over 4 weeks rather than 8 to really be able to allow patients in active treatment with advanced cancer to be able to participate without it being overwhelming. The group size was about 8, which I think, Dr. Atreya and I both felt like 8 to 10 felt like a very cohesive group where we could learn from each other and it not be overwhelming again. We had some really specific confidentiality and consent agreements that we're happy to share out with other groups. And actually, we learned from other groups at the Osher Center, like Jamie Cohen's group for survivorship. And so, and importantly, just the first note which is the idea that we had group and individual time really made a difference, I think, for how patients responded, because they could learn from the group. And if there was something that they didn't feel comfortable potentially expressing in the group, they were able to share that in the individual time. We talked about Zoom and the access that provided. And importantly, a shout out to Ivan Leung and Sandy Cuevas, who were staffing to really help the participants deal with the technology issues. Dr. Atreya and I couldn't be so mindful if we were having to do that. And so having them on board was was really game-changing, to be honest. And then allowing multiple locations where folks could come in from the infusion center being driven from the waiting room. We wanted to make sure that we had a process that really empowers patients and that was centered on diversity, equity, inclusion, access. And so here, again, the slide will be busy. I'll just give a couple highlights. We had a range of practices, and that included meditations from across cultures, including, Qigong, chair yoga, twin hearts, meditation from Bhutan that I really appreciate, this shaking and dancing exercise that has some indigenous Middle Eastern, South Asian roots. There was a key concept of inner wisdom, which really goes to the fact that mindfulness taps into acknowledging what's happening for us inside, and also taps into potentially the wisdom that may live inside. And so as patients started to feel that and see that and share that, we could see that difference in the room of patients realizing that, yes, in fact, I have this inner wisdom if I can tap into it. And that changes the power dynamic and really affects the process. We tried to do a really representative job in terms of having the slides, quotes, references, be of diverse background. We always acknowledged gender pronouns and encouraged participants to do so as well. And one of the most important pieces on this slide is the feedback loop, where we were very open to allowing and encouraging patients and team members to give us feedback orally, written, in clinic, whatever. And then we would make modifications based on that. And that might be in terms of the physical exercises, it may be in terms of the group flow. For example, there were times where something may come up from a number of patients around compassion, and I might adjust the meditation at the closing to include a bit of self-compassion. And so allowing that flexibility for a co-facilitator to make those adjustments was really critical, both within a session, if that's doable, and then also between sessions and between series. We had one patient who had real food insecurity, and so Dr. Atreya added verbiage around that into her mindful eating exercise, which was really important. And there were some logistics, obviously, that we also adjusted. We're working on home practice resources, and also importantly, we would try to name cultural origins of the exercises. And then the final P is power, shifting the dynamics to better integrate voices and priorities. So again, all of this was in that idea of how can we achieve equity and empowerment in the most sustainable, meaningful way. And so one of the key concepts here was that that would come through those 4 weeks with each patient group was the idea that we are all learners and we are all teachers. From the day we are born, I think, until the last day that we're around. And so I learned from a baby as much about unconditional love, awe, wonder, joy, as I do from my 95-year-old patient. And so that concept of really equalizing the playing field, that we are all facilitators in a way, and actually as a facilitator in the group exercise, we would participate. And then we really tried to make the group sharing about sharing versus advising. Tried to keep space for different belief systems, and we've talked about the feedback. And Dr. Atreya will talk about some of our trauma-informed practices.
Great, thank you. So trauma-sensitive or trauma-informed mindfulness is an area of special interest to me, following trainings with Mushim Ikeda at the East Bay Meditation Center, and also David Trelevin, whose book is pictured here on the left. And trauma is more common among BIPOC identified people, and cancer itself can be experienced as trauma. So examples of trauma-sensitive practices include offering alternatives to focusing on the breath, including grounding on a neutral object in the room, naming that it's okay to leave one's eyes open during meditation and also to move, and providing verbal cues before inviting the bell at the end of a meditation. And during the individual sessions, I also ask patients how the meditation went for them, and if any particular emotional or difficult thoughts, emotional challenges or difficult thoughts came up during the meditation, and together we come up with tailored practice suggestions, and then we have the opportunity to check in again the next week. And one thing that I've noticed is that for someone who may be experiencing a trauma response 1 week, they may have worked with it and kind of transformed it and may be experiencing something different in the next week. Back to you.
Thank you. All right, so in our last handful of minutes, I want to take us from sort of the details of what we've been talking about with the group medical visit to a bit of a bird's eye view, and in terms of how we think about tailoring mind-body medicine for the diverse individual. So we've talked about the quantitative analysis, we've talked about the qualitative analysis, and really using this equity and empowerment lens, which we continue to use to guide us. We also use a theoretical construct for meditation to really help us individualize care. And I just find this cartoon hilarious because it sort of feels like how we all live our life, which is, what's the meaning of life? But make it quick. I've got an important meeting in half an hour. And he's helicoptering into the top of the Himalayas with this guru. So in the getting sort of philosophical and theoretical in the contemplative practices, there are a few different models that really resonate for me. And one model is this, which describes the insights that may come from meditational practices. And it groups it into three: attentional, constructive, and deconstructive. So the kinds of wisdoms that may come out of these practices are listed here, things like concentration, focus in the attentional category, kindness, loving compassion towards the self and others in the constructive category, and deconstructive being some of the existential type of questions of what is reality, what is impermanence, how are we interconnected? And from some of those initial models, there were other models that grew, and I'm not going to go into this into detail. That's like spending half hour with the guru on top of the mountain. Not saying that I'm the guru, but this meditational model is a guru. And so, but importantly, what happened is some of the models grew from those initial concepts, and this one is the developmental stage model of meditation, and it's designed as a pyramid, and it includes stages of growth. And what I tried to do was work with some collaborators actually across the Osher centers, and really tried to adapt this theoretical model to clinical application. And so just to spend a minute on this, in adapting from theory to practice with patients, there are some really critical concepts that come out. Number one, fluidity. You know, in modern science, and I feel the same way, we often like to bucket things into clean patterns, triangles, you know, buckets. But the human experience can be quite variable and quite fluid. And so in adapting that theoretical model, I built it in as a infinity sign because that resonated for me as this idea of how do you really acknowledge that learning can be a fluid journey through those different stages. And you may go into one stage, back, forward, back a bit more. And it's really not a forward back thing. It's really a development of those different learnings and those concepts over time. And so really maximizing that flexibility is crucial for patients, especially in advanced cancer and in active treatment. Number two, diversity. And so acknowledging the diversity of practices, the diversity of types of wisdoms that may resonate for any one patient at any one point. And this is not only throughout the entirety of the cancer journey, but really even with the ups and downs of each treatment cycle. And then third, centering. And in the center of that infinity sign is this thing that says everyday way of being. And the idea is that the ultimate focus is to bring that practice into our daily life so that we're really living mindfully in all of our moments, sort of eating, breathing, loving, acting mindfully. And as Dr. Atreya and I thought about how do we take these different constructs, scientific, sociocultural, theoretical, how do we bring it to deliver personalized meditation to our patients over the course of these 4 weeks, both in the individual setting and in the group setting. So again, this slide has a lot of details in it. We would take bits and pieces and nuggets and share with patients as it felt to resonate. And so we may pick a few practices and discuss those with patients, see what resonates. And we would try to really build in SMART goals and give details so that it was a prescription that was very specific for patients and measurable. One comment I'll just highlight here is mind-body medicine snacks. One of our colleagues, Dr. Natalie Marshall, started talking about exercise snacks, and obviously we have nutritional snacks. And the concept of using, 1 or 2 minutes in the waiting room or small minutes that we can use for mind-body medicine snacks was something that really resonates for me and for patients as well. And then assessment. So during the weeks, we would then go back to those guidelines and say, hey, what was working, what wasn't, what are the barriers, with compassion and forgiveness and appreciation, because the last thing we want is to have guilt. And so this was how we thought about personalizing meditation. So to close out, I think the really important pieces of what Dr. Atreya and I have appreciated is, number one, there are critical gaps that exist in the current knowledge with mind-body medicine and group practices for integrative oncology. Centering mind-body medicine group visits on equity and empowerment is feasible and essential and was really meaningful for both of us. And using theoretical as well as practical constructs can empower us to empower diverse patients with personalized prescriptions. And next steps are really trying to manualize what we are formulating here, tailoring practices for patients, including in different languages, and then really trying to do an efficacy study ultimately. A shout out for this Integrative Oncology Symposium that will be happening on November 4th, 1 o'clock to 4 o'clock. We have the lovely Dr. Linda Carlson, who Dr. Atreya was able to bring on board to start us off, and then we'll have local experts to discuss much of what we were talking about today, as well as many other subjects. And then a massive thank you to all the folks on this slide. Nothing happens in a vacuum, and so it always takes a village, and this is our village, which we really appreciate. And a special shout out to Christine Pollock, Ivan Leung, who just put in a lot of effort throughout the time. So thank you very much.
Thank you so much, both of you. Absolutely fantastic. We have many, many questions I will attempt to synthesize and ask you right now. I did want to note what a just outstanding example this is of truly applying an integrative health equity approach. So often, I think we find ourselves at least somewhat pleased when there is an equity lens applied at some point to a project. It tends to be towards the end, unfortunately, and often it's kind of a veneer or a layer, an attempt of readjusting. And what you've shown here, which really expresses a core value of the Osher Center in terms of striving for integrative health equity, is incorporating that from the beginning. So it's really a part of everything that you do. So it's not only such a wonderful exemplar in terms of group medical visits, but I think a really critical approach for integrative health equity in general. So thank you both so much for that. And let me now synthesize a great many questions. Some of the questions have to do with the idea of billing and this type of group medical visit. So I'm going to read one of these. This is from Dr. Sarah Patterson. Sarah, indicate if you'd like to ask this yourself, but I will begin looking out of the corner of my eye for a wave from you. Can you give a description of the criteria that need to be met for a program to be considered a collection of group medical visits? Is the primary difference between your programs and other mindfulness programs like MBSR, for example, that the groups are led by physicians? Dr. Patterson says, it strikes me that much of the content is similar to MBSR, and I'm curious if you received any pushback from insurers when it came to reimbursement. And she asks because you've presented a model that we should be considering for other chronic diseases, not surprisingly, rheumatologic diseases.
Mm-hmm. Chloe, you want me to take that one? So great question, Sarah, and something that we have definitely spent a lot of time on figuring out how to bill effectively, how to bill appropriately. And there's a great resource. I'm going to mess up the name probably, but the Integrative Center for Group Medical Visits, something like that. Paula Gardner is one of the folks who's involved, and she actually has a number of online resources. So Sarah, let's make sure to connect if this is something that you're interested in. But basically, as we learned about different billing models, people are trying different, institutions are really varied across the US. And we talked to Stanford, we talked to Sloan Kettering, we talked to others. Paula Gardner. And basically what we've, couple things. One is you can bill by time or complexity. And yes, because we are physicians, we are able to bill insurance. And actually we have not had significant issues with authorization. Many of these patients are either seen by Dr. Atreya or myself or others in the OSHR or oncology sectors. And so we were able to get authorization if needed. Otherwise, many didn't actually need authorization. And it was 4 weeks versus 8 or 10 weeks, which maybe would cause other red flags to go up. But there weren't any red flags that went up on that. And then in terms of billing, we really tried to be appropriate and to either the time that we spent with patients through those hours. And then also, frankly, Dr. Trey and I spent a lot of time before and after setting, on the day of and other days as well, setting up the series, and then making sure that we had AVS and notes and that resources were sent to patients in terms of time. And then in terms of complexity, because we are two physicians, actually part of what complexity, thanks for putting that in the chat. Part of what you can bill in terms of complexity is if you actually have a discussion with another MD, which Dr. Trey and I would always talk through each of the patients afterwards and reflect, resonate, see what else we needed to do with each patient. And so that also counts towards complexity, sort of level 3 to 4, et cetera. So we can talk through the details because I'm sure there are other questions, but yes, it is a feasible model. It is being looked at by multiple centers across the US.
Can I just make one quick
Yes, of course.
which is just that my note template, so we have note templates in Apex, and so I will cite all of the NCCN guidelines and the American Cancer Center guidelines that support the work that we're doing. So you will, in the near future, probably be seeing more should recommendations for these sort of practices and upcoming guidelines. And so it becomes a question of like, this is the care that our national, guidelines creators that the insurance companies are looking toward, are saying that we should deliver. So now it's a question of how do we deliver it?
Yeah. And we did, Sarah, talk with the billing folks at UCSF and medical legal to just make sure everything was packaged correctly and the wording was right in the notes, which we'll share.
Fantastic. Thank you so much.
Thanks for the question, Sarah. There are several questions related to remote versus in-person visits, and you've gone over some of the significant barrier reductions geographically, a whole bunch of other reasons, parking. But what has been sort of deeply your experience delivering care and information online? And what is your sense of what the patients are experiencing? And are there ways you're trying to overcome some of the gaps of not being in person?
Chloe, you want to start with this one?
I'm trying to think. I think we had more perceived barriers, and I think this is something that Dr. Abrams went through also, that when he started his groups, they were in person. I remember having conversations with him about, I'll never want to do them virtually. And I think he's had a really good experience virtually. And with EBMC, we've had, that same transition. And I have to say that, yes, there's something really nice about being in each other's presence in person, and yet the ability, the number of patients were like, okay, this person wouldn't be able to attend today if we were meeting in a physical location at this time. And the comfort of being in one's own space and being able to, sometimes people would check out for a period of time if something really emotional came up. And so I think that it's been a really good experience overall.
Yeah, I would agree with that wholeheartedly. I think there are pros and cons. I think in terms of really that diversity lens also, having that ability to join in from different locations, different mental spaces, physical spaces, was really meaningful. Mm-hmm. And surprisingly, one can get into that mindful space over Zoom, which I think all of us were surprised by initially.
Yes, certainly having the broad catchment area is something we've experienced also in terms of recruiting for fellowships and absolutely. There are also some notes that as we become more used to Zoom, many of us who thought, who would ever want to do this, are realizing not only is it much better than when we couldn't have anything in person, but also moving forward, there's an evolution of comfort and familiarity with people who are leading the sessions and also the patients themselves. And a follow-up to that question, I'm going to try and get a couple more questions in here. Did the participants cultivate relationships with one another? Do you know if anyone stayed in touch or tried to develop any kind of ongoing maintenance program for themselves?
Yeah, for sure. I can start, Chloe, and you can add in. Yeah, we had some really beautiful relationships form, actually. Surprisingly, we had a couple in some of the first pilots that actually would start to plan their infusions together. And so they would, schedule that in so that they could actually see each other live, which obviously we didn't do or even promote, but they kind of figured that out together. And then we certainly had people who would develop practices and then share that back with us, either at the clinical setting afterwards, where they were developing practices, mostly on an individual basis, but every now and then also with other participants. Chloe, anything to add?
That we did try to do a couple of alumni sessions. So we had a couple of alumni Qigong sessions. Those actually weren't very well attended. And I think we need to do a little bit more work to figure out what the barriers were there, if it was just not at a good time or other factors.
And what we're learning in our MBCT studies is the alumni groups being reconstituted groups from previous cohorts can also change the dynamic in a way that people don't always find as appealing. Let me see, get one last question in. There are many questions, and I'm going to ask people to contact you directly if they would like to pursue these questions, but having to do with how this type of program can be implemented throughout UCSF, in other centers and departments. And I think the core issue here is what kind of either clinical experience or training do you think is needed to facilitate this kind of group? Many people are asking for sort of the materials, the structure, but what do you recommend someone do or have to prepare themselves to lead this type of group?
Yes, Circle.
Yeah, briefly, one thing that Dr. Mishra and I both do, and I think it helps with that, that we're all learners and teachers, is that we speak from our own practices. So when I started when I started being present, soon after taking MBSR, which was an important foundation for me, I wasn't ready to develop or lead this group. So I would say that having a deep practice oneself is important. And also, being able to respond to whatever comes, it really helps to have that experience as facilitator. Now, I think we can bring on co-facilitators who don't need to have that same role, but I think that having at least one facilitator, and ideal if we can have two facilitators with that deep personal mind-body experience.
Yeah. I think that's right. And I'll just add in that if folks are interested in training towards this, personally, MBSR training, not only taking a course, but then there's actual training that one does where you train to be a facilitator. So that is very meaningful, helpful. MBCR, Mindfulness-Based Cancer Recovery, if you're in the cancer world in particular, that's been a really meaningful training. And then I'd say for me in particular, the Center for Mind-Body Medicine training was a really special, slightly different kind of take on mind-body medicine. So if anyone's interested in learning more about those trainings, happy to share.
Terrific. Well, thank you. I'm afraid those are the only questions we're going to be able to address. Again, much gratitude to both of you. This is absolutely fantastic work that has clearly such a remarkably significant impact. Please imagine raucous applause virtually. And it's a pleasure to have both of you. Thank you so much.